Welcome, everybody, to another NSG Fireside Chat. Always a pleasure to be able to answer questions and concerns from our patients. Also, always a pleasure to share expertise with our cutting-edge neurosurgeon, Dr. Jared Ament, who is truly one of the most prolific researchers in this area. A lot of my patients have been asking me, how do you know that I would benefit from an artificial disc more than any other operation? And there's many ways to skin a cat in spine surgery. So we wanted to just spend a few minutes sharing some of our thoughts because I've been performing neurosurgery for over 20 years, and it really does take a significant amount of time and sophisticated strategy to do cutting edge artificial disc surgery well. And that's one of the things that we master at NSG and are always striving for even higher levels of mastery. So without further ado, I really look forward to hearing thoughts from Dr. Ament regarding this and sharing some of my own insights.
Yeah, no, Dr. Vokshur is, other than the flattery, which I always appreciate, is 100% correct. This is so nuanced, and I think we run the risk, not just us, but as a profession, of becoming kind of this one size fits all solution. And the artificial disc concept has become sexy, and not everyone is a candidate. I mean, people reach out to us all the time saying artificial disc, and it's just not something that's viable. With that said, you and I are pushing the envelope and are putting artificial discs into people that would have otherwise been fused 10 or 15 or 20 years ago, not because it's unsafe, but because we truly believe it's the right thing to do with respect to motion preservation, quality of life, and the future. I think one of the more interesting.
I'd like to pick that up. Actually, you just really hit a really good nugget there, which is pushing the envelope and being sexy does not need to be at a cost of efficacy or minimally invasiveness. There are safety. There are patients who still undergo fusions for cases that we would actually perform artificial discs at, and I think that's the most important takeaway point here, is that we're not trying to do it for everybody, but when it's possible to push the envelope, we prefer motion preservation over other strategies, and it actually takes a much higher amount of effort in surgery. And maybe you can comment on that a little bit, just the nuances of what it takes surgically, technically, to do an artificial disc well, as opposed to all the other operations, even a microdiscectomy from the back of the neck, for example.
Well, I mean, the issue you just brought up is an important one. The concept of fusion, it's not that we're, like you said, we're not trying to do something unsafe, but the concept of fusion is to stabilize something that's unstable, right? To fix instability. And in the past, that was the only viable option. So degenerative diseases, changes that require these big decompressions, where we have to go in there and manipulate the anatomy, in essence, we were creating instability, and the only option left was to stabilize and therefore fuse. So pushing the envelope, sounds sexy or unsexy, depending on your perspective, especially if safety comes into question. But really, we are also at the whim of technology, right? Technology has changed, and we are currently involved in multiple FDA trials looking at the latest and greatest of artificial discs, because technology continues to evolve. And so if we are going to do a surgery and we're going to put an artificial disc in place where one would have done a fusion to stabilize, you ask about nuances. There are certain subtleties. We have to look at the joints. There's joints in the front, there's joints in the back. And if we're going to have a restorative motion surgery, we need to make sure that motion is working properly, right? Abnormal motion is still a bad thing, right? We don't want to just give motion. So when we're doing this surgery, we want to make sure that we are decompressing adequately, symmetrically, safely, and the positioning of this artificial disc is not only going to work physiologically, but it's going to heal in place and remain physiologic. And that's really important. A lot of people are used to really being aggressive with that decompression, using the drill, taking off, a little bit of end plate here and there. And a lot of the kind of tried, tested, and true techniques fail in motion preservation surgery. And
very important.
Yeah, I think it's
Indeed.
the one thing I want to say though about artificial disc surgery, and this is something that you and I talked a little bit about on Instagram and other marketing kind of avenues, but it's true, is one of the things that we're talking about is this personalized or targeted motion preservation surgery. We don't, the trials that we are involved in, we are picking discs for a particular patient. We're not saying that we just love one disc or love two discs and we're going to use it for everyone. It's not a cookie cutter sizing. And it's really important that when you talk about nuances, it's not just surgical nuances. It's understanding that the technology is different for everyone, and that a smaller person with smaller discs with different range of motion, with different bone quality may benefit from one disc versus another.
A lot of kinematic specifics that are really patient specific. Dr. Amond, I often get asked by patients when they've had multiple opinions, why do you still think an artificial disc will be safe for me specifically? And they realize that we are very much committed to motion preservation, and we're committed to FDA trials. We're committed to evidence-based way of treating disc disease in the cervical spine. But there are specific circumstances where a patient's anatomy traditionally has always required, based on traditional thinking and sort of, I'd say, dogmatic training, always required fusion. And now, with the advent of trial after trial of artificial discs showing at least equivalence, if not superiority, to ACDF, which is cervical fusion, we have this new way of thinking, and I think you and I are at the forefront of that. But I want to specifically get your thoughts on these circumstances. So I'm going to give you 3 or 4 different clinical scenarios, and I'd like for you to say, number one, is artificial disc technology contraindicated, relatively contraindicated, or absolutely okay to consider it? And obviously, there's nuances, and we previously in the last session talked about the technical nuances of treating the end plate and looking at the joints. But I'll give you these clinical scenarios. One is,
all right, shoot.
Yeah, so the first one is kyphosis. If you have segmental, regional, or global kyphosis, and I know both you and I have done this in surgical scenarios, but I wanted to specifically sort of get you on record talking about kyphosis. And the way we looked at it, we looked at kyphosis as a deforming condition. Therefore, it's a cervical, spinal deformity, which is treated with stabilization and fusion. So symptomatic cervical kyphosis with a disc bulge / herniation, that's symptomatic.
Yeah, so the answer would be somewhere between relative contraindication and okay. And the reason why I say that is that there is degenerative kyphosis, and for the viewers, kyphosis, he means this kind of leaning forward of the neck. It's the reversal of the normal angulation, lordosis of
the hunchback.
Yeah. So, I mean, the big issue here is, one, we're assuming the kyphosis isn't unstable. So we're going to document that, because then it's a contraindication. 2, depending on the patient, could a disc height restorative process give them enough correction that they could fix the kyphosis themselves, right? So there is data that if you offload the facet, if you restore the disc height, and you have a relatively healthy person, strong person that goes to enough physical therapy and enough Pilates and really works on their posture, they can develop some of the musculature to help either prevent the kyphosis from progressing or even potentially reverse it. And I guess that's a little bit controversial. But the question is, why is that kyphosis happening in the first place? If the kyphosis is happening because of degenerative disc disease and just pain and poor muscular tone and structural support, then sure, I don't understand why anyone would have to fuse. And an artificial disc is just as good as, should be just as good as the disc that you were born with. And if they've degenerated, you give them new disc, let them work on bringing them back into a more natural lordotic state with motion preserved. So that's a tough question, but that's my philosophy. I'm not sure the data supports one or the other, to be honest with you, because the only thing
I wholeheartedly agree. That's one of the areas we don't have a lot of data in. Yeah. But you raised 2 or 3 different points that I want to make sure the viewers understand. One is check for its stability. So we do dynamic x-rays and look at the kinematics of each motion segment. And looking at that looks for translational, rotational, or angular motion or instability. That's a, there's some criteria based on x-ray findings, and these digital x-rays can pick that up. Another one you picked up, you mentioned, was what causes kyphosis. So we have physiologic kyphosis. We can have post-traumatic kyphosis that may or may not be still grossly unstable. So that's what Dr. Ament is mentioning. So we can certainly go into some details about that. But for the interest of time, I want to move on to my next question, which is, Dr. Ament, in the setting of a very large disc herniation, large enough to cause cervical spinal cord compression and even spinal cord symptoms, which are things like tingling in the hands, instability while walking, and even an electric shock sensation down the spine, in the neck, or in the arms. In that setting, traditional thinking, and when I was trained, is fusion 100%. And I think now we have better disc technology, et cetera. And I think both you and I in that setting could potentially, again, push the envelope, but want to hear you talk about that.
Well, Dr. Vokshar, I will remind you that we had a patient like this come in through the emergency room once, and you questioned me on me booking an emergency artificial disc replacement. And my rebuttal was very simple, was I don't understand why what we put in the place of the disc after the decompression is a question of emergent versus elective. The emergency is decompressing the spinal cord. What goes in there, and you've kind of, but again, you're right. Your traditional teaching, everyone's traditional teaching has been decompress the spine and stabilize it. But the thought process is very simple here. If there's no instability, you're decompressing the spinal cord in an emergency setting. If you are going to preserve motion, there should not be a problem, even in the setting of myelopathy, of spinal cord injury, because the spinal cord should normally move. And without some insulting thing, pathology being there is no reason why an injured cord moving is any different than a non-injured cord, right? And moving.
That's a very good point. That's a very good point. I'd like to also remind you, one of my concerns about that case was the unfortunate situation of emergency surgery without insurance authorization in the United States that we're facing right now. So the insurance companies that are often clinging to extremely old and dated ways of thinking about how to deal with spinal pathology, and even some of their physicians' hands are tied. Even physicians that are hired by insurance companies that know better tell us on a daily basis that, based on the policy that this insurance company, Blue Cross, Blue Shield, et cetera, has deployed currently, this surgery will not be covered. And so in that particular scenario, I was actually concerned with the patient being left with a massive hospital bill, not to speak of our bill even. But even if we do it as charity, the insurance company, having outdated and archaic policies, could look at that surgery and deny a patient's hospitalization, even though you and I both know it was emergently indicated.
Sure, but you are also the one person that will always remind me and tell me at the end of the day, we do what's right for the patient. And in my
100%.
opinion, a young patient with even a traumatic disc, with no other signs of instability, I think that the emergency is decompressing the spinal cord, and what you leave in its place should be based on some relative normal indicators that we would use on a daily basis. And this sort of antiquated perspective that you have to stabilize spinal cord injury, I think is wrong. I think stabilizing an unstable spine, stabilizing instability makes sense. That is the right way to practice. But I just don't understand why you can decompress the spine and you suddenly have to immobilize it. Decompress it and give it the motion it always had. I mean, to me, as long as there's motion, not around an insult, a constant insult, right? You don't want an injured spinal cord to be constantly injured.
So I wholeheartedly agree, but to be a devil's advocate, I'd like to bring you this additional nuance. And let's say you have the choice of 2, 3, 4 artificial discs in that scenario. And in the kyphosis setting, would you choose a artificial disc that may have a lordotic capability? And in the large disc herniation setting, would you choose a more constrained device rather than unconstrained device? And what would make you go through that thought process? Obviously, much more, I would say, a much more complicated conversation that we have time
Yeah.
for, but just a few bullet points would be wonderful.
I think as the artificial disc, to answer your first question about kyphosis, as the artificial disc technology continues to evolve, we're going to have more and more options when it comes to potentially restoring lordosis and angulation within that artificial disc space. And that is an evolving conversation. I think people are using hybrids, mixing and matching, because the fusions allow you to do more restoration in and around. I think it's yet to be determined, but the goal is decompress the spine, preserve motion, and maintain alignment to the best of our ability. So as you and I know, we're involved in a trial that has a lordotic angulated disc option. We will see, but theoretically and philosophically, we both agree that there's potentially benefit there. The last question, more constrained versus not constrained. Again, theoretically, in a large disc herniation with spinal cord injury, theoretically, what you're saying makes sense to go more constrained, but I still believe that that thinking implies that there's something wrong with a less constrained disc in the setting of spinal cord injury. If you would put a less constrained disc into a person, then you should be able to put a less constrained disc into a person. And if there is no chance that that less constrained disc is going to cause repeated insults to an injured cord, there's no reason why I can't go into an injured cord. And that's the question. Are we worried about constraint and draping of the cord or angulation and continued injury? So to answer your question, if you're worried about continued injury, you either fuse or put in a more constrained disc. If you're not, and it's a young patient and there's good angulation and lordosis, and you think that this is just a one-off bad disc herniation and the patient will recover and has a strong neck and good physical therapy, you put in the disc you think is right for the patient.
That is a perfect segue to my third question. And I know we're a little constrained on time, but I even if this segues to our next conversation, I'd like to bring that up. And that is, in the very setting that you just described, and I treat a lot of patients with connective tissue disorders that are in the extreme of laxity and flexibility. But then I feel like we're looking at an entire, I would say, an entire span of different levels of spinal flexibility that is inherent to each patient and sometimes each segment. So in the setting of the large disc herniation, do you match the flexibility of the segment? Is that how you choose your implant, to say this, the stiffness of this disc, the constraint of this disc matches this patient the best, not not even thinking about a person with connective tissue disorder or gross instability? And are we there yet? Because I think that's, to me, a customizable implant that matches the inherent kinematics of the motion segment is what would be ideal. So I'd love to hear your comments on
that's
that.
that's the personalized targeted approach that we're talking about. I mean, you and I are putting different artificial discs at different segments into the same patient. And I think that we're getting there. Are we there yet? I think in the acute ruptured disc trauma setting, you can't tell what the normal kinematics of that disc are anymore. So in that setting, I think our hands are a little bit tied. We're limited in data. In the elective setting, when we look at actual intradiscal segmental range of motion, not just global range of motion, then we're getting there. We have different levels of constraint, different angulations, and we can be very customizable. Is there a disc that can be customized to that level of granularity and nuances? It doesn't exist yet. There are kind of bigger gaps in kind of the customizable options, but we're better off than we ever were. I mean, look, on my board exam, they asked me about a patient with degenerative disease that was 30 something years old that we didn't know he had a degenerative disease. And we did this hybrid scenario and was kyphotic, and they questioned me about it. And it was one of those conversations.
I have to remind the audience, when I did my board exam, there were no artificial discs.
It came up a lot on the board exam, and the comments, they were receptive, but the comments were interesting. Your practice is regionally different than the standard of care in the United States. And obviously I didn't argue during the board examination, but I thought about it a lot afterwards, and I'm like, regional to what? I mean, we are so behind in some regards, and this is another segue, but the concept of hybrids, mixing fusions and artificial discs or multi-level artificial discs is not new. The Australians, the Chinese, the Europeans, Germany and Spain have been doing it for well over a decade, if not more. And we are a little bit behind the eight ball, that for some reason fusion has been the standard of care for so long that it's hard for us to kind of extrapolate what could be next. And I wish
fantastic segue to my fourth question.
Yeah.
And I know we were very constrained, so we can actually even take this up another time. But a lot of our patients are asking, well, why did FDA not approve this at 3 levels or 4 levels? And it's like it takes a lot of just explaining the FDA process to our patients. Well, how come you're trying to put a disc that hasn't been approved at 2 levels for my kinematics? What is that about? And I certainly just want you to hint on that, and we can pick that up another time. But really, you just hit some really amazing bullet points, and really appreciate it. For the audience, another really important thing, we practice in Los Angeles, California, and that's what Dr. Ament means by regional differences, because what is standard of care, or what's being seen in the community in, say, Beverly Hills, Santa Monica, etc., is not exactly what's being seen in Montana. And I don't know the reasons for that, but one of the reasons is this concept of pushing the envelope. And one of the reasons we have these conversations is to say safety first. And we're not just cowboys. We're trying to do the right thing for the patient each step of the way to get the best outcome possible. But so if you can finish the segment by commenting on how to navigate the concept of FDA approval and on-label, off-label use in hybrid scenarios, etc.
Well, I mean, I think everything you said is obviously correct, and I agree with your perspective. And I think the FDA, look, the red tape that people complain about in the United States is designed in many ways to keep people safe. And there's a lot of examples of where places don't have red tape and people get harmed. But, the FDA, to do an FDA trial is extremely expensive, and you rely on industry and venture capitalists. It becomes messy and becomes dirty because medicine requires a huge influx of cash to satisfy FDA requirements. And the FDA themselves will very clearly make this comment. And I think this is very important for people to understand. An FDA approved device means that it's been approved under very strict conditions for a certain amount of time, in a certain amount of scenarios. But it doesn't mean that a physician or a surgeon cannot use an FDA approved device for another indication. And they leave that up to the discretion of the physician. It's very clear that that's the legality behind the FDA. And there's a lot of medicines that people take that are being used for non-FDA on-label reasons. So gabapentin was an initial seizure medicine that's used more for neuropathic pain. It's not even used for seizures anymore. I mean, it is a slippery slope, because you can start saying, oh, well, let's just replace the whole spine with artificial discs. I mean, this has to be done responsibly. The FDA has to conduct itself responsibly, and physicians and surgeons have to take the data and the information garnished from these trials and use it responsibly. And I think that's the crux. You said we're not cowboys. The goal is to do things safely, but not be hampered by limitations either, if we truly believe that patients can benefit. But we're following these patients. We have data. We're collecting down at every single patient. Trust me, they're all annoyed half the time we ask them to fill out all those surveys, but they realize it and they appreciate it.
Oh, yes. Thank you for filling your surveys to all our patients. You make us so happy when you actually go through the process, and we understand that it's painstaking. In trials, patients get a little bonus, little gift card for filling out this. Yeah. So
thank you, Dr. Bulge, for the fireside questions, not just the chat.
It's always a pleasure. I think this back and forth really helps both of us and helps our patients, and also, I think it really helps us realize that we are on the right track to decipher kind of the next level evolution of spine surgery. So with that, thank you very much, and to next time.
Thank you.
Take care, everybody.